In this lecture, I will be discussing the general approach to clinical diagnosis of dermatologic conditions based on proper history taking and physical exam.
Here is my outline. A small introduction, then I will go over the important points in history taking and how to properly examine and diagnose skin conditions. And I will introduce the different types of skin lesions that we usually encounter. So dermatology is a specialty that deals with the skin. The skin is the largest organ of the body and can reach up to 2 meters squared in surface area. It is frequently referred to as the mirror of the body, as many internal conditions have cutaneous manifestations, which may be the clue for diagnosis, and hence it is an integral part of most medical specialties. When a patient presents with skin lesions, interpretation can sometimes be difficult. That's because different skin diseases may have identical manifestations, making it hard to differentiate between them. On the other hand, a certain disease may vary in appearance, and that's because skin lesions are dynamic and change with time, whether due to the natural progression of the disease or due to external alterations. To illustrate this further, here are examples of similar annular lesions with erythematous borders and central clearing. Similar morphologies, yet different entities. So this is what you see with some fungal infections or bacterial infections or other reactive processes. A certain entity can present in various forms. You see here a collection of nevi with different morphologies. They can be erythematous, skin-colored, or pigmented, raised or flat, and so on. Here is another example. Warts or verruca are due to an HPV infection. Clinically, they may appear as small, slightly raised papules, or filiform or cauliflower-like lesions, or even larger plaques. Lesions are dynamic, meaning they may change with time. A patient with acne vulgaris may have lesions in different stages, such as comedones, erythematous papules, pustules, and excoriations. Psoriasis can present with small scaly papules that later progress into bigger plaques, covering large areas of the body. So in order to properly diagnose a condition, we need to take a good medical history and thoroughly examine the patient and identify what we refer to as primary and secondary lesions. Now we start with the history taking. When a patient presents with a chief complaint, it is important to inquire about its onset and characterize the signs and symptoms, whether they are acute or chronic, constant or periodic, and whether lesions are itchy, painful, or burning. We should determine their location and distribution. In cases where an infection or a hereditary condition is suspected, we should ask about affected household and other family members. We must also ask about the progress and evolution of lesions, whether they change with time or have been altered by therapy, whether there is seasonal variation. A thorough history of drug intake is important as many medications have cutaneous manifestations or alter the course of skin diseases. In some conditions, we must inquire about the use of cosmetics, especially in acne patients or in cases of facial dermatitis. We need to ask about occupational history. For instance, allergic and irritant contact dermatitis are both common conditions among hairdressers, beauticians, and healthcare workers. Veterinary and sanitation workers are at high risk of contracting skin infections. Recreational history, exposure to pets, animals, etc. And the type of clothing. This might be relevant in cases of dermatitis, reactive skin, etc. And in some cases, a travel history may be helpful when investigating the possibility of infectious diseases. Take, for example, a patient presenting with an itchy serpiginous rash involving the feet and buttock few days after coming back from a trip to Zanzibar. This is highly suggestive of cutaneous larva migrans, since the area is endemic for soil-transmitted helminthiasis. Another example is a patient with crops of very pruritic erythematous papules along the waistline, feet, arms, and other exposed sites that developed following a hotel stay. These may be bite reactions to bedbugs.
So always dig deep in the history. Inquiring about past medical history, whether personal or family history, is also required for particular skin conditions, as some are hereditary, such as psoriasis and ichthyosis. Furthermore, checking for a history of allergy, asthma, hay fever is helpful in cases related to atopy. Finally, underlying systemic diseases like endocrinopathies and malignancies, among others, may be present in association with some skin disorders. Once done with the history taking, we move to the physical exam. For a proper physical exam, we require adequate illumination. We rely on the natural white light. And we often use in the clinics magnifiers that are equipped with a white light. To describe skin lesions, we first have to learn the language of dermatology. It's a common language that we share and that allows us to determine the morphology of lesions. In other words, their general appearance without any regard to their pathogenesis or their underlying etiology. So during the physical exam, the first thing we do is identify what we refer to as primary and secondary lesions, not only by visual inspection but also by palpation. So the lesion by definition is an alteration of skin. Primary lesions are those that develop de novo without any preceding skin change. Secondary lesions are those that evolve or change in appearance with time. We need to recognize them in order to reach a proper diagnosis. So what are the primary lesions we usually encounter? A macule is a flat circumscribed area with an altered color or discoloration and less than 1 centimeter in size. And if it is larger than a centimeter, we refer to it as a patch. This alteration in color can be due to epidermal or dermal changes. The skin has a normal feeling upon palpation. These pictures show a case of vitiligo with depigmented patches and a case of melasma with hyperpigmented macules and patches. A papule is a small, circumscribed, firm elevation of the skin less than 1 centimeter in size. When it is flat-topped, we refer to it as a lichen. It may be of different colors. When greater than 1 centimeter in size and flat-topped, we refer to it as a plaque. This is a case of psoriasis where you see large scaly plaques and few smaller papules. A nodule is a firm skin lesion larger than 1 centimeter in size and that extends into deeper layers of the skin, the dermis or the subcutaneous tissue. The surface forms a raised bump. A cyst is a cavity lined by epithelium and filled with fluid or semi-solid material such as keratin. A wheal is an evanescent or transient, oval, round, or irregular, slightly elevated lesion, characteristically with a pale center and a pink flare or margin. It occurs due to swelling in the dermis. This is the primary lesion in urticaria or hives. A vesicle is a small, less than a centimeter circumscribed, elevated fluid-containing lesion. When larger than that, we refer to it as a bulla. These are usually confined to the epidermis, but bulla may be subepidermal as well. A pustule is similar to a vesicle but filled with pus. A comedon is an impaction of keratin within the infundibulum of a pilosebaceous unit. It is the primary lesion of acne vulgaris. Petechiae, purpura, and ecchymosis are basically blood spots and are the result of bleeding into the skin. The different names are used depending on the size. So a petechiae is less than 2 millimeters, purpura is between 2 to 10 millimeters, and ecchymosis is more than 10 millimeters in size. They can be the result of vascular fragility in older age groups, referred to as senile purpura, or can be due to vasculitis, among other conditions. Telangiectasias are dilated capillaries that are permanently visible on the skin surface. Now we move to the secondary lesions, which are lesions that evolve over time. They do not appear de novo like the primary lesions. Scales are thickened, loose, readily detached fragments of stratum corneum. So they consist of keratin. They appear as white flakes due to increased cell turnover or accumulation of dead skin cells due to abnormal exfoliation. They are commonly seen in psoriasis, for example, whether on small papules or larger plaques. A crust is formed from dried exudate overlying irritated or injured skin. The exudate can be blood, serum, or pus. It is not to be confused with the scale. An excoriation is a shallow, punctate, or linear abrasion of the epidermis, and sometimes dermis, often caused by scratching. An erosion is a loss of a portion of the epidermis, so the top layer, and not extending to the dermis. The surface is moist and it usually heals without leaving any scar. An ulcer is an excavation due to full thickness loss of the epidermis, along with damage to the dermis or the subcutaneous tissue. It may have a rolled border and usually leaves behind scars. A fissure is a linear cleft into the skin extending to the dermis. It is usually painful and may occur due to excessive dryness of skin. This is to recapitulate a comparative diagram between the different types of defects mentioned. So the excoriation and erosion are shallow lesions, the ulcer is a deeper lesion, and the fissure is a very neat linear cleft. The scar is a permanent lesion that results from the process of repair of defects by replacement of normal tissue with fibrous tissue. Scars may be atrophic, so thinned out, depressed skin, or hypertrophic, so extends beyond the surface of the skin. Atrophy is loss of tissue, whether it is epidermal, dermal, or even subcutaneous. The skin becomes thinned and wrinkled. It can occur due to topical steroid use, steroid injection, aging, inflammatory skin conditions, or poor circulation. Lichenification is thickening of the skin with prominent skin markings, often due to repeated chronic rubbing, as with chronic dermatitis. Induration is dermal thickening produced by excessive deposition of collagen or by dermal infiltrative process. Palpation is crucial to appreciate induration, as it may not be evident by visual inspection alone. Burrows, which are typically seen in scabies infection, are tunnels in the epidermis produced by the burrowing mite Sarcoptes scabiei. A cutaneous horn is an excessive accumulation of stratum corneum in a localized area and usually overlies an inflammatory process, whether be it malignant or benign. Apart from the primary and secondary lesions, there are descriptive terms one needs to be familiar with. Discoid or nummular refers to round or coin-shaped lesions such as with nummular dermatitis. Targetoid lesions are round lesions with a concentric border and a dark center, so iris-like. Annular lesions are ring-shaped with an active border and a clear center. A snake-like pattern is referred to as serpiginous, such as with cutaneous larva migrans, caused by hookworms. A gyrate pattern, as the name implies, is arcuate or polycyclic and is typical of some paraneoplastic eruptions like erythema gyratum repens that may be associated with some esophageal, lung, and breast cancers. Verrucous or papillomatous lesions have a surface consisting of finger-like projections. They resemble cauliflowers, and this is very descriptive of warts. Guttate eruptions exhibit small lesions similar to water drops distributed over the body. An umbilicated lesion has a central depression, commonly seen with poxvirus infections. The Kubner phenomenon is the reproduction of skin lesions in certain diseases at sites of trauma or injury. An example is lichen planus. New lesions appear at the site of scratching. Herpetiform lesions are grouped as with herpes simplex infections.
Apart from the shape, we should check the demarcation of the lesions, if they are clearly defined or not. Erysipelas, for example, typically has a well-demarcated border, whereas cellulitis can be ill-defined. Same with vitiligo. It is usually very well defined, versus pityriasis alba, for example, which has indistinct margins. The color is another variable. Vitiligo looks white. Drug rashes, bright red. Kaposi sarcoma, purple. Granulomas can be brown. Xanthomas or fatty deposits, yellow. Scars and necrotic skin, black. And we can have a blue color for deep pigmentation, such as blue nevi. Finally, we should determine the distribution of the lesions. Are they localized or widespread? Do they follow a certain pattern? For example, zoster-iform or dermatomal lesions follow the distribution of a nerve, such as with shingles or herpes zoster.
A reticulate pattern is net-like and seen with vasculopathies or other dermatosis. Lesions can be linear, so follow a line. Photodistributed lesions appear over sun-exposed skin. Protected areas remain free of disease. This is common with certain drug phototoxic reactions and photosensitive disorders such as lupus erythematosus and other connective tissue diseases, to name a few.
This table summarizes what we discussed so far. Moving on with the physical exam, remember that during the exam we need to inspect all the skin surface. This includes not only the skin, but also the hair, nails, and mucous membranes. Why is it then so important to examine the whole skin? Take this case for example. A patient comes in complaining of an itchy erythematous annular scaly plaque over the abdomen. This is suggestive of ringworm or a fungal infection. However, when you undress the patient, you notice he has multiple, much smaller papules and plaques, some with fine scales distributed over his back. At this point, the differential diagnosis is in favor of a post-viral reaction. So always ask patients to undress and perform a full skin exam, as they may disregard signs relevant to their condition.
On occasion, after proper history taking and physical examination, additional tests are needed to confirm the diagnosis. We often rely on microscopic examination. A KOH smear will confirm the diagnosis of fungal infection by revealing mycelia or spores. Skin scrapings show the presence of ectoparasites such as scabies mites or their eggs. Examining the hair reveals nits and sometimes lice in cases suspicious for pediculosis. Light microscopy is also useful in examining various hair shaft abnormalities in some genodermatosis and other disorders affecting the hair. Zinc smears help in confirming viral infections. In herpes, we look for multinucleated giant cells. Other tests helpful in the clinical assessment include Nikolsky's sign, which is an induction of a fresh bulla by pressing on the skin of patients with bullous disorders. In cutaneous mastocytosis, if you stroke or rub a lesion, you induce degranulation of mast cells, leading to the development of a wheal. This is known as Darier's sign. In psoriasis, scraping of the scale induces pinpoint bleeding. This is known as Auspit's sign. Clinical digital photography is becoming more and more essential for clinical research, diagnosis, and monitoring of therapeutic response and evolution of lesions. The dermatoscope has become our preferred tool. It is a non-invasive, handheld magnifying device that helps in differentiating between various lesions, in evaluating and recognizing suspicious ones, thus determining the need for biopsy or excision. The pictures show three lesions clinically similar, yet very different by dermoscopy. The Woods lamp is also a handheld device that emits a broadband light between 320 to 400 nanometers. By exposing the skin in a dark room to the light, a distinctive fluorescence results specific to certain disorders, such as fungal or bacterial infections. It also helps in pigmentation disorders. It can accentuate epidermal hyperpigmentation, or, as in the case of vitiligo, detect areas of depigmentation which may not be very evident by regular light exam. Patch testing is useful to confirm allergies. And finally, in many cases, we ultimately revert to biopsy for histopathologic examination in order to reach a final diagnosis. Our favorite motto is the following: when in doubt, biopsy. So, in a nutshell, the initial approach to the patient presenting with a skin problem requires a detailed history of the current skin complaint. A full body skin examination, including the scalp, nails, and mucosal surfaces, is recommended. Inspection is not enough. We need to palpate and identify the morphology and distribution of skin lesions and determine the primary and secondary lesions. A variety of diagnostic tools are at our disposal to help us in our assessment.